Hi, good afternoon. My name is Lisbeth Armijos. I am going to speak about the Canagliflozin renal outcomes in type 2 diabetes nephropathy. First, we have the definition. Canagliflozin is used along with a proper diet and exercise program and sometimes with other medications to control high blood sugar in people with type 2 diabetes, a condition in which the blood sugar is too high because the body doesn't normally produce or use insulin.
Understanding type 2 diabetes. Type 2 diabetes is a metabolic disorder that causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel by the cells in our body. When we eat, food is broken down by our digestive system into nutrient molecules that are then absorbed through our digestive tract for use by the body. Foods containing carbohydrates or various sugars are broken down into glucose. Glucose is an important source of fuel for many organs in our body. However, to be able to use the glucose for fuel, the glucose molecule must first enter into the cell.
Now we have the application in medicine that in the canagliflozin and renal outcomes in type 2 diabetes and nephropathy study, 4,401 diabetic patients were randomized to receive 100 milligrams of canagliflozin versus placebo. All of them were taking ACE inhibitors, that is angiotensin converting enzyme inhibitors, or ARBs, that is angiotensin 2 receptor antagonists. The primary objective, defined as ESRD renal compositive, that is dialysis arrival renal transplant or glomerular filtration rate ES than 15 milliliters minutes, 173 meters quadrant, or two times or more of the basal creatinine, doubling or more of the baseline creatinine, or renal death or cardiovascular death.
Welcome back. In this video, we'll talk about the antidiabetic drugs of the class sodium glucose cotransporter inhibitors. These are the medications ending with the suffix gliflozin, and they're used to treat type 2 diabetes. Almost all glucose reaching the kidneys is filtered, and it passes into the renal tubules, where it should be eventually excreted in urine. However, there is a receptor in the proximal convoluted tubules called the sodium glucose cotransporter. This receptor reabsorbs sodium and glucose together. That's why it's called cotransporter. It's responsible for the reabsorption of about 90% of glucose, and it has a threshold of about 200, which means that anything more than 200 will be excreted in urine. For example, if sugar level was 250, 200 will be reabsorbed by this transporter, and 50 will be filtered in the urine. Antidiabetic drugs of this class, like canagliflozin, work by inhibiting this transporter, which results in excessive glucose loss in the urine. This, of course, makes the patient prone to UTIs, as bacteria thrive on sugar. And because the receptor is also responsible for sodium reabsorption, the patient will be severely dehydrated, as the presence of sodium and glucose inside the tubules pulls water into the lumen by osmosis.
So now we have the pros. Canagliflozin is in a class of medication called sodium glucose cotransporter 2, that is SGLT2 inhibitors. Canagliflozin lowers blood sugar by causing the kidneys to remove more glucose in the urine. About the cons, we have that over time, people who have diabetes and high blood sugar can develop serious or life-threatening complications, including heart disease, stroke, kidney problems, nerve damage, and vision problems. Canagliflozin is not used to treat type 1 diabetes, condition in which the body doesn't produce insulin and therefore can't control the amount of sugar in the blood. Now, I'm going to speak about the issue applied in Ecuador that currently study in Ecuador on the drug canagliflozin I have not found. However, inquired about an article where they indicate that the Chilean Public Health Institute, that is ASP, has reported that it is in the process of reviewing the safety content of the information brochures for professionals and patients of pharmaceutical products that contain canagliflozin, dapagliflozin, and empagliflozin, belonging to the group of sodium glucose transport type 2 SGLT2 inhibitors, indicate to treat type 2 diabetes mellitus in adult patients. As indicated in an informative pharmacovigilance note, that these reviews in carried out because in the last year information has been released on an increased risk of non-traumatic amputation, especially in the toes, associated with canagliflozin, as well as case of diabetic ketoacidosis of unusual presentation and several cases of acute renal failure with the use of these three antidiabetics. For this reason, it's necessary to warn health professionals and patients about these new risks and inform about the measures to prevent their appearance, the authorities said in the letter. Conclusion: in type 2 diabetes, in the last 15 years and since the classical renal study with losartan or IDNT with irbesartan, all studies with multiple therapeutic targets had failed in the treatment of diabetic nephropathy. If these results are confirmed in clinical practice, many diabetics will delay or not reach dialysis, and we will always have reduced a significant part of their cardiovascular risk. The good results of the CREDENCE study add to the effective nephroprotection achieved with this family in much less advanced stage of diabetic kidney disease.
So the last one we looked at today was canagliflozin for the treatment of type 2 diabetes. This is a completely novel drug that causes glucoseuria, causes glucose in the urine to be excreted, so that patients excrete calories basically in their urine, and this is the mechanism of action. It's unlike any prior therapy for type 2 diabetes. The biggest difference here is its effect on weight, because calories literally come out in the urine. So some of the calories that patients ingest don't even end up contributing to their weight, but come out in the urine. It causes the most weight loss of any of the drugs available for type 2 diabetes. And this is the big difference really compared with existing treatments. It is safe in the short-term studies that allowed it to be approved by the FDA. It does not cause hypoglycemia in monotherapy. It causes about the same degree of A1C reduction as other treatments for type 2 diabetes. but causes significantly more weight loss. In fact, some of the other drugs actually cause weight gain when they're taken for diabetes. There's two safety issues. The side effect is kind of an unusual one because glucose appears in the urine. There's an increased risk of fungal infections, fungal balanitis for men, and vaginal candidiasis for women, and probably simply relates to the milieu of the extra sugar in the urine being sort of a petri dish for candida infections to develop. Those are generally, not serious and treatable. The one long-term issue which hasn't been completely addressed yet is whether it might be related to increased risk for certain types of cancers. So the FDA has required post-marketing surveillance for this drug to see if in fact that is the case. They did not think that was likely enough.